C. Chapter-specific coding guidelines. In addition to general coding guidelines, there are guidelines for specific diagnoses and/or conditions in the classification. Unless otherwise indicated, these guidelines apply to all healthcare settings. Please refer to Section 2 for guidelines on the selection of principal diagnosis. 1. Chapter 1. Certain infectious and parasitic diseases. AOOB 99, U07, 1, U09.9. A. Human immunodeficiency virus, HIV, infections. 1. Code only confirmed cases. Code only confirmed cases of HIV infection, illness. This is an exception to the Hospital Inpatient Guidelines Section 2, H. In this context, confirmation does not require documentation of positive serology or culture for HIV. The provider's diagnostic statement that the patient is HIV positive or has an HIV-related illness is sufficient. 2. Selection and sequencing of HIV codes. A. Patient admitted for HIV-related condition. If a patient is admitted for an HIV-related condition, the principal diagnosis should be B20, human immunodeficiency virus, HIV disease, followed by additional diagnosis codes for all reported HIV-related conditions. An exception to this guideline is if the reason for admission is hemolytic uremic syndrome associated with HIV disease. Assign code D59.31, infection-associated hemolytic uremic syndrome, followed by code B20, human immunodeficiency virus, HIV disease. B. Patient with HIV disease admitted for unrelated condition. If a patient with HIV disease is admitted for an unrelated condition, such as a traumatic injury, the code for the unrelated condition, e.g., the nature of injury code, should be the principal diagnosis. Other diagnoses would be B20 followed by additional diagnosis codes for all reported HIV-related conditions. C. Whether the patient is newly diagnosed. Whether the patient is newly diagnosed or has had previous admissions, encounters for HIV conditions is irrelevant to the sequencing decision. D. Asymptomatic human immunodeficiency virus Z21. Asymptomatic human immunodeficiency virus, HIV, infection status, is to be applied when the patient without any documentation of symptoms is listed as being HIV positive, known HIV, HIV test positive, or similar terminology. Do not use this code if the term AIDS or HIV disease is used, or if the patient is treated for any HIV-related illness or is described as having any conditions resulting from his/her HIV positive status. Use B20 in these cases. A. Patients with inconclusive HIV serology. Patients with inconclusive HIV serology, but no definitive diagnosis or manifestations of the illness, may be assigned code R75, inconclusive laboratory evidence of human immunodeficiency virus, HIV. F. Previously diagnosed HIV-related illness. Patients with any known prior diagnosis of an HIV-related illness should be coded to B20. Once a patient has developed an HIV-related illness, the patient should always be assigned code B20 on every subsequent admission, encounter. Patients previously diagnosed with any HIV illness, B20, should never be assigned to R75 or Z21, asymptomatic human immunodeficiency virus, HIV, infection status. G. HIV infection in pregnancy, childbirth and the puerperium. During pregnancy, childbirth or the puerperium, a patient admitted or presenting for a healthcare encounter because of an HIV-related illness should receive a principal diagnosis code of O98.7, human immunodeficiency, HIV, disease complicating pregnancy, childbirth and the puerperium, followed by B20 and the codes for the HIV-related illness, S. Codes from Chapter 15 always take sequencing priority. Patients with asymptomatic HIV infection status admitted or presenting for a healthcare encounter during pregnancy, childbirth, or the puerperium should receive codes of O98.7 and Z21. H. Encounters for testing for HIV. If a patient is being seen to determine his/her HIV status, use code Z11.4. Encounter for screening for human immunodeficiency virus, HIV. Use additional codes for any associated high-risk behavior, if applicable. If a patient with signs or symptoms is being seen for HIV testing, code the signs and symptoms. An additional counseling code Z71.7, human immunodeficiency virus, HIV, counseling, may be used if counseling is provided during the encounter for the test. When a patient returns to be informed of his/her HIV test results and the test result is negative, use code Z71.7, human immunodeficiency virus, HIV, counseling. If the results are positive, see previous guidelines and assign codes as appropriate. I. HIV managed by antiretroviral medication. If a patient with documented HIV disease, HIV-related illness or AIDS is currently managed on antiretroviral medications, assign code B20, human immunodeficiency virus, HIV, disease, code Z79.899, other long-term, current, drug therapy, may be assigned as an additional code to identify the long-term, current, use of antiretroviral medications. B. Infectious agents as the cause of diseases classified to other chapters. Certain infections are classified in chapters other than Chapter 1 and no organism is identified as part of the infection code. In these instances, it is necessary to use an additional code from Chapter 1 to identify the organism. A. Code from Category B95, Streptococcus, Staphylococcus, and Enterococcus as the cause of diseases classified to other chapters. B96, other bacterial agents as the cause of diseases classified to other chapters, or B97, viral agents as the cause of diseases classified to other chapters, is to be used as an additional code to identify the organism. An instructional note will be found at the infection code advising that an additional organism code is required. C. Infections resistant to antibiotics. Many bacterial infections are resistant to current antibiotics. It is necessary to identify all infections documented as antibiotic resistant. Assign a code from category Z16, resistance to antimicrobial drugs, following the infection code only if the infection code does not identify drug resistance. D. Sepsis, severe sepsis, and septic shock infections resistant to antibiotics. 1. Coding of sepsis and severe sepsis. A. Sepsis. For a diagnosis of sepsis, assign the appropriate code for the underlying systemic infection. If the type of infection or causal organism is not further specified, assign code A41.9, sepsis, unspecified organism. A code from subcategory R65.2, severe sepsis, should not be assigned unless severe sepsis or an associated acute organ dysfunction is documented. I. Negative or inconclusive blood cultures and sepsis. Negative or inconclusive blood cultures do not preclude a diagnosis of sepsis in patients with clinical evidence of the condition. However, the provider should be queried. E. Urosepsis. The term urosepsis is a non-specific term. It is not to be considered synonymous with sepsis. It has no default code in the alphabetic index. Should a provider use this term, she must be queried for clarification. E. Sepsis with organ dysfunction. If a patient has sepsis and associated acute organ dysfunction or multiple organ dysfunction, MOD, follow the instructions for coding severe sepsis, IV, acute organ dysfunction that is not clearly associated with the sepsis. If a patient has sepsis and an acute organ dysfunction, but the medical record documentation indicates that the acute organ dysfunction is related to a medical condition other than the sepsis, do not assign a code from subcategory R65.2, severe sepsis. An acute organ dysfunction must be associated with the sepsis in order to assign the severe sepsis code. If the documentation is not clear as to whether an acute organ dysfunction is related to the sepsis or another medical condition, query the provider. B. Severe sepsis. The coding of severe sepsis requires a minimum of 2 codes. First, a code for the underlying systemic infection, followed by a code from subcategory R65.2, severe sepsis. If the causal organism is not documented, assign code A41.9, sepsis, unspecified organism, for the infection. Additional codes for the associated acute organ dysfunction are also required. Due to the complex nature of severe sepsis, some cases may require querying the provider prior to assignment of the codes. 2. Septic shock. Septic shock generally refers to circulatory failure associated with severe sepsis, and therefore, it represents a type of acute organ dysfunction. For cases of septic shock, the code for the systemic infection should be sequenced first, followed by code R65.21, severe sepsis with septic shock, or code T81.12, post-procedural septic shock. Any additional codes for the other acute organ dysfunctions should also be assigned. As noted in the sequencing instructions in the tabular list, the code for septic shock cannot be assigned as a principal diagnosis. 3. Sequencing of severe sepsis. If severe sepsis is present on admission, and meets the definition of principal diagnosis, the underlying systemic infection should be assigned as principal diagnosis followed by the appropriate code from subcategory R65.2 as required by the sequencing rules in the tabular list. A code from subcategory R65.2 can never be assigned as a principal diagnosis. When severe sepsis develops during an encounter, it was not present on admission, the underlying systemic infection and the appropriate code from subcategory R65.2 should be assigned as secondary diagnoses. Severe sepsis may be present on admission, but the diagnosis may not be confirmed until some time after admission. If the documentation is not clear whether severe sepsis was present on admission, the provider should be queried. For infection-associated hemolytic uremic syndrome with severe sepsis, see Guideline IC1, D.9. 4. Sepsis or severe sepsis with a localized infection. If the reason for admission is sepsis or severe sepsis and a localized infection, such as pneumonia or cellulitis, a code for the underlying systemic infection should be assigned first and the code for the localized infection should be assigned as a secondary diagnosis. If the patient has severe sepsis, a code from subcategory R65.2 should also be assigned as a secondary diagnosis. If the patient is admitted with a localized infection, such as pneumonia, and sepsis, severe sepsis doesn't develop until after admission, the localized infection should be assigned first, followed by the appropriate sepsis, severe sepsis codes. For hemolytic uremic syndrome associated with sepsis, see Guideline IC1, D.9. 5. Sepsis due to a post-procedural infection, a documentation of causal relationship. As with all post-procedural complications, code assignment is based on the provider's documentation of the relationship between the infection and the procedure. B. Sepsis due to a post-procedural infection for infections following a procedure, a code from T81.40 to T81.43 infection following a procedure, or a code from O86.00 to O86.03, infection of obstetric surgical wound, that identifies the site of the infection should be coded first, if known. Assign an additional code for sepsis following a procedure, T81.44, or sepsis following an obstetrical procedure, O86.04. Use an additional code to identify the infectious agent. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned with the additional codes for any acute organ dysfunction. For infections following infusion, transfusion, therapeutic injection, or immunization, a code from subcategory T80.2, infections following infusion, transfusion, and therapeutic injection, or code T88.0, infection following immunization, should be coded first, followed by the code for the specific infection. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned, with the additional code S for any acute organ dysfunction. C. Post-procedural infection and post-procedural septic shock. If a post-procedural infection has resulted in post-procedural septic shock, assign the codes indicated above for sepsis due to a post-procedural infection, followed by code T81.12, post-procedural septic shock. Do not assign code R65.21, severe sepsis with septic shock. Additional codes should be assigned for any acute organ dysfunction. 6. Sepsis and severe sepsis associated with a non-infectious process, condition. In some cases, a non-infectious process, condition, such as trauma, may lead to an infection which can result in sepsis or severe sepsis. If sepsis or severe sepsis is documented as associated with a non-infectious condition, such as a burn or serious injury, and this condition meets the definition for principal diagnosis, the code for the non-infectious condition should be sequenced first, followed by the code for the resulting infection. If severe sepsis is present, a code from subcategory R65.2 should also be assigned with any associated organ dysfunctions codes. It is not necessary to assign a code from subcategory R65.1, Systemic Inflammatory Response Syndrome, SIRS, of non-infectious origin, for these cases. If the infection meets the definition of principal diagnosis, it should be sequenced before the non-infectious condition. When both the associated non-infectious condition and the infection meet the definition of principal diagnosis, either may be assigned as principal diagnosis. Only one code from category R65, symptoms and signs specifically associated with systemic inflammation and infection, should be assigned. Therefore, when a non-infectious condition leads to an infection resulting in severe sepsis, assign the appropriate code from subcategory R65.2, severe sepsis. Do not additionally assign a code from subcategory R65.1, Systemic Inflammatory Response Syndrome, SIRS, of non-infectious origin. See section IC18, SIRS due to non-infectious process. 7. Sepsis and septic shock complicating abortion, pregnancy, childbirth, and the puerperium. See section IC15, Sepsis and septic shock complicating abortion, pregnancy, childbirth and the puerperium. 8. Newborn sepsis. See section IC16, F. Bacterial sepsis of newborn. 9. Hemolytic uremic syndrome associated with sepsis. If the reason for admission is hemolytic uremic syndrome that is associated with sepsis, assign code D59.31, infection-associated hemolytic uremic syndrome, as the principal diagnosis. Codes for the underlying systemic infection and any other conditions, such as severe sepsis, should be assigned as secondary diagnoses. A. Methicillin-resistant Staphylococcus aureus, MRSA, conditions. 1. Selection and sequencing of MRSA codes, a. Combination codes for MRSA infection. When a patient is diagnosed with an infection that is due to methicillin-resistant Staphylococcus aureus, MRSA, and that infection has a combination code that includes the causal organism, e.g., sepsis, pneumonia, assign the appropriate combination code for the condition, e.g., code A41.02, sepsis due to methicillin-resistant Staphylococcus aureus, or code J15.212, pneumonia due to methicillin-resistant Staphylococcus aureus. Do not assign code B95.62, methicillin-resistant Staphylococcus aureus infection as the cause of diseases classified elsewhere, as an additional code, because the combination code includes the type of infection and the MRSA organism. Do not assign a code from subcategory Z16.11, resistance to penicillins, as an additional diagnosis. See section C1, for instructions on coding and sequencing of sepsis and severe sepsis. B. Other codes for MRSA infection when there is documentation of a current infection, e.g., wound infection, stitch abscess, urinary tract infection, due to MRSA, and that infection does not have a combination code that includes the causal organism. Assign the appropriate code to identify the condition along with code B95.62, methicillin-resistant Staphylococcus aureus infection as the cause of diseases classified elsewhere for the MRSA infection. Do not assign a code from subcategory Z16.11, resistance to penicillins. C. Methicillin-susceptible Staphylococcus aureus, MSSA, and MRSA colonization. The condition or state of being colonized or carrying MSSA or MRSA is called colonization or carriage, while an individual person is described as being colonized or being a carrier. Colonization means that MSSA or MSRA is present on or in the body without necessarily causing illness. A positive MRSA colonization test might be documented by the provider as MRSA screen positive or MRSA nasal swab positive. Assign code Z22.322, carrier or suspected carrier of methicillin-resistant Staphylococcus aureus, for patients documented as having MRSA colonization. Assign code Z22.321, carrier or suspected carrier of methicillin-susceptible Staphylococcus aureus, for patients documented as having MSSA colonization. Colonization is not necessarily indicative of a disease process or as the cause of a specific condition the patient may have unless documented as such by the provider. D. MRSA colonization and infection. If a patient is documented as having both MRSA colonization and infection during a hospital admission, code Z22.322, carrier or suspected carrier of methicillin-resistant Staphylococcus aureus, and a code for the MRSA infection may both be assigned. F. Zika virus infections 1, code only confirmed cases. Code only a confirmed diagnosis of Zika virus, a 92.5, Zika virus disease, as documented by the provider. This is an exception to the hospital inpatient guideline section 2, H. In this context, confirmation does not require documentation of the type of test performed. The provider's diagnostic statement that the condition is confirmed is sufficient. This code should be assigned regardless of the stated mode of transmission. If the provider documents suspected, possible, or probable Zika, do not assign code A92.5. Assign a codes explaining the reason for encounter, such as fever, rash, or joint pain, or Z20.821, contact with and suspected exposure to Zika virus. G. Coronavirus infections 1, COVID-19 infection due to SARS-CoV-2. A. Code only confirmed cases. Code only a confirmed diagnosis of the 2019 novel coronavirus disease, COVID-19, as documented by the provider, or documentation of a positive COVID-19 test result. For a confirmed diagnosis, assign code U07, 1, COVID-19. This is an exception to the hospital inpatient guidelines section 2, H. In this context, confirmation does not require documentation of a positive test result for COVID-19. The provider's documentation that the individual has COVID-19 is sufficient. If the provider documents suspected, possible, probable, or inconclusive COVID-19, do not assign code U07.1. Instead, code the signs and symptoms reported. See Guideline IC1, G.1, G, B, sequencing of codes when COVID-19 meets the definition of principal diagnosis. Code U07, 1, COVID-19, should be sequenced first, followed by the appropriate codes for associated manifestations, except when another guideline requires that certain codes be sequenced first, such as obstetrics, sepsis, or transplant complications. For a COVID-19 infection that progresses to sepsis, see section IC1, D, sepsis, severe sepsis, and septic shock. See section IC15, S, for COVID-19 infection in pregnancy, childbirth, and the puerperium. See section IC16, H, for COVID-19 infection in newborn. For a COVID-19 infection in a lung transplant patient, see section IC19, G.3, A. Transplant complications other than kidney. C. Acute respiratory manifestations of COVID-19 when the reason for the encounter, admission is a respiratory manifestation of COVID-19, assign code U07, 1, COVID-19, as the principal, first listed diagnosis and assign codes for the respiratory manifestations as additional diagnoses. The following conditions are examples of common respiratory manifestations of COVID-19. I. Pneumonia for a patient with pneumonia confirmed as due to COVID-19, assign codes U07, 1, COVID-19, and J12.82, pneumonia due to coronavirus disease 2019. E. Acute bronchitis for a patient with acute bronchitis confirmed as due to COVID-19, assign codes U07, 1, and J20.8, acute bronchitis due to other specified organisms. Bronchitis not otherwise specified, NOS, due to COVID-19 should be coded using code U07, 1 and J40, bronchitis, not specified as acute or chronic. E. Lower respiratory infection if the COVID-19 is documented as being associated with a lower respiratory infection, not otherwise specified, NOS, or an acute respiratory infection, NOS, codes U07, 1 and J22, unspecified acute lower respiratory infection, should be assigned, if the COVID-19 is documented as being associated with a respiratory infection, NOS, codes U07, 1 and J98.8, other specified respiratory disorders, should be assigned, IV, acute respiratory distress syndrome. For acute respiratory distress syndrome, ARDS, due to COVID-19, assign codes U07, 1, and J80, acute respiratory distress syndrome. V. Acute respiratory failure for acute respiratory failure due to COVID-19, assign code U07, 1, and code J96.0, acute respiratory failure. D. Non-respiratory manifestations of COVID-19 when the reason for the encounter, admission is a non-respiratory manifestation, e.g., viral enteritis, of COVID-19, assign code U07, 1, COVID-19, as the principal, first listed diagnosis and assign codes for the manifestations as additional diagnoses. A. Exposure to COVID-19 for asymptomatic individuals with actual or suspected exposure to COVID-19, assign code Z20.822, contact with N, suspected, exposure to COVID-19. For symptomatic individuals with actual or suspected exposure to COVID-19 and the infection has been ruled out, or test results are inconclusive or unknown, assign code Z20.822, contact with N, suspected, exposure to COVID-19, see guideline IC21, C.1, contact, exposure, for additional guidance regarding the use of category Z20 codes. If COVID-19 is confirmed, see guideline IC1, G.1, A. F. Screening for COVID-19 during the COVID-19 pandemic, a screening code is generally not appropriate. Do not assign code Z11.52, encounter for screening for COVID-19, for encounters for COVID-19 testing, including preoperative testing, code as exposure to COVID-19, guideline IC1, G.1, A. Coding guidance will be updated as new information concerning any changes in the pandemic status becomes available. G. Signs and symptoms without definitive diagnosis of COVID-19 for patients presenting with any signs, symptoms associated with COVID-19, such as fever, etc., but a definitive diagnosis has not been established, assign the appropriate codes for each of the presenting signs and symptoms such as R05, 1, acute cough, or R05, 9, cough, unspecified, R06.02 shortness of breath, R50.9 fever, unspecified. If a patient with signs, symptoms associated with COVID-19 also has an actual or suspected contact with or exposure to COVID-19, assign Z20.822, contact with N, suspected, exposure to COVID-19, as an additional code. H. Asymptomatic individuals who test positive for COVID-19 for asymptomatic individuals who test positive for COVID-19, see guideline IC1, G.1, A. Although the individual is asymptomatic, the individual has tested positive and is considered to have the COVID-19 infection. I. Personal history of COVID-19 for patients with a history of COVID-19, assign code Z86.16, personal history of COVID-19. J. Follow-up visits after COVID-19 infection has resolved. For individuals who previously had COVID-19, without residual symptoms or conditions, and are being seen for follow-up evaluation, and COVID-19 test results are negative, assign code Z09, encounter for follow-up examination after completed treatment for conditions other than malignant neoplasm, and Z86.16, personal history of COVID-19. For follow-up visits for individuals with symptoms or conditions related to a previous COVID-19 infection, see Guideline IC1, G.1, M, see Section IC21, C.8, Factors influencing health states and contact with health services, follow-up. K. Encounter for antibody testing. For an encounter for antibody testing that is not being performed to confirm a current COVID-19 infection, nor is a follow-up test after resolution of COVID-19, assign Z01.84, encounter for antibody response examination. Follow the applicable guidelines above if the individual is being tested to confirm a current COVID-19 infection. For follow-up testing after a COVID-19 infection, see Guideline IC1, G.1, J. L. Multisystem inflammatory syndrome. For individuals with multisystem inflammatory syndrome, MIS, and COVID-19, assign code U07, 1, COVID-19, as the principal, first listed diagnosis and assign code M35.81, multisystem inflammatory syndrome, as an additional diagnosis. If an individual with a history of COVID-19 develops MIS, assign codes M35.81, multisystem inflammatory syndrome, and U09, 9, post-COVID-19 condition, unspecified. If an individual with a known or suspected exposure to COVID-19, and no current COVID-19 infection or history of COVID-19, develops MIS, assign codes M35.81, multisystem inflammatory syndrome, and Z20.822, contact with an suspected exposure to COVID-19. Additional codes should be assigned for any associated complications of MIS. M. Post-COVID-19 condition. For sequelae of COVID-19, or associated symptoms or conditions that develop following a previous COVID-19 infection, assign a codes for the specific symptoms or conditions related to the previous COVID-19 infection, if known, and code U09, 9, post-COVID-19 condition, unspecified. Code U09.9 should not be assigned for manifestations of an active, current, COVID-19 infection. If a patient has a conditions associated with a previous COVID-19 infection and develops a new active, current, COVID-19 infection, code U09, the 9th of may be assigned in conjunction with code U07, 1, COVID-19, to identify that the patient also has a conditions associated with the previous COVID-19 infection. Codes for the specific conditions associated with the previous COVID-19 infection and codes for manifestations of the new active, current, COVID-19 infection should also be assigned. N. Endimmunization. For COVID-19, status code Z28.310, unvaccinated for COVID-19, may be assigned when the patient has not received a COVID-19 vaccine of any type. Code Z28.311, partially vaccinated for COVID-19, may be assigned when the patient has been partially vaccinated for COVID-19 as per the recommendations of the Centers for Disease Control and Prevention, CDC, in place at the time of the encounter. For information, visit the CDC's website. Web links. See section IB14 for endimmunization documentation by clinicians other than patient's provider.